So technology has obviously transformed medicine in ways that are too numerous to count, and we've reached a new phase in technology's impact on healthcare. It's a time when man and machine technology, they begin to take us in directions we never thought imaginable, but we can blend them, and that gives physicians power that's good, and power can be used the wrong way. I'm joined by two innovators who will describe healthcare technology that seems to come from the pages of science fiction. Virtual reality, which is something that I've been fascinated by and is gaining huge traction nationally. Please welcome David Rhew and Mike Muller. And David's going to start off with some PowerPoints, I believe, right?
That's right. Can I just say what a pleasure it is to be here. I want to thank Robin, I want to thank the Cura Foundation, the Pontifical Council for Culture for hosting such an amazing and important event. So just a little background on myself. My name is Dave Rhew. I'm the Chief Medical Officer for Samsung. And let me just go there. One of the things that you probably think about Samsung, you know us for the smartphones, you know Samsung for the TVs, the home appliances. But what you may not realize is that Samsung actually has a deep and long-standing commitment to healthcare. So a really good example is in 1994, Samsung established the Samsung Medical Center, which is a large tertiary care facility based in South Korea. And it is one of the most advanced technological hospitals in that area. And we have a mission to improve the health of 1 billion people by 2020. So that means we really have to go outside of the hospital setting and even outside of our facilities and think, how can we do that? So digital health is a big part of what we've been trying to do. And as we think about digital health, there's so many different ways that we can engage the patient and the consumer and healthcare providers. But one that has really gotten a lot of attention, and rightfully so, is virtual reality. And when we think of virtual reality, we typically think of it as a tool for entertainment, and maybe these are mechanisms where we could provide some value of improving the experience in a hospital, or maybe even as a means for medical training. But what we're really talking about is something different here. We're talking about using virtual reality to treat medical conditions. And as part of that, we sometimes refer to this as therapeutic VR. So to give you some ideas of how this is currently being used, I'd like to show you a video, and then we'll talk a bit about the science behind that. So we could run the video, please.
A star Paralympian who lost most of her vision as a teenager has been granted the gift of sight thanks to an incredible piece of technology. Jess Gallagher received a life-changing virtual reality headset.
Today, she was given a priceless gift, the ability to see clearly again after losing most of her vision at age 17.
I don't have the ability to see facial expressions, what somebody's wearing, and right now I can see everything. It's pretty amazing.
The virtual reality headset will help her outlook go from this to this.
Bob Jester is this kind of exceptional guy. He was a teacher for 39 years. He won all these awards. He's a volunteer fireman. He is always helping people.
Last August, while I was working at a man's house, I fell from the chimney. I broke 19 bones. I had several rods put in my back and 16 bolts. And when I woke up, found myself with no use of my legs and no control of anything below my waist. And that's where this adventure began. I didn't think a human could experience that much pain. I started to put together things that I can use to try to alleviate some of the pain, but at the same time not depend on the chemical meds as much. One of the weapons in my arsenal is the applied VR virtual reality. If I'm having real serious pains and I feel like I want to take another oxy, a lot of times I'll strap it on. I can refocus my attention to flying on the Wright's airplane, or looking at animals out on the plains, or looking at farm animals. It would take my attention away from the pain But I learned in my mind how to do that same thing for an hour or two after I used it. I have no intention of staying in this wheelchair. And some of the doctors say I'm never going to walk. I'm just telling you, okay, you personally. Okay, I'm going to walk out of Mechanic Landing someday. The future of virtual reality in healthcare is probably limitless.
So what's really amazing, over the past 10 years, we've seen an explosion in terms of the amount of research being done in virtual reality to treat medical conditions. And I'd attribute it to three main reasons. First is that the technology itself has gotten a lot better. So the visual clarity around this, the ability to hold content on a phone, is just at the point where it creates such a vivid and immersive experience. And the second is the fact that it's mobile. So now anyone, anywhere can be able to take this. They can do it in clinics, they can do it in outpatient facilities, even in one's home. So it allows researchers to be able to experiment on conditions and patients that they hadn't even thought of before. And the third is the cost. It's so incredibly inexpensive. And when you combine those three factors, now we have researchers everywhere studying this on conditions that we hadn't even envisioned. And we're starting to see great research on post-traumatic stress disorder, stroke, visual issues. And one of the areas that we have found maybe it advancing even faster, perhaps because we're in the midst of an opioid epidemic, is pain management. So I wanted to share with you, in that space, there's actually a lot of literature, but most recently we worked with Cedars-Sinai Medical Center. It's a large community hospital based in Los Angeles, California, to implement a randomized controlled trial of 120 patients. And in this study, half of them that were randomized to virtual reality, where they saw maybe a 10 to 15 minute video, sort of what you had seen with Bob, for typically 10 to 15 minutes, but just once a day. And then they would evaluate them to see how they were doing. And most of these folks were medical surgical patients. They were cancer patients. They were patients post-surgery. And the control group, interestingly enough, actually watched the same type of content on a TV screen. So to some degree, it was almost like two interventions. And they really wanted to make sure that there was something different about that immersive experience. And what they found is a 52% reduction in this randomized control trial with a statistical significance less than 0.05, where pain was reduced. And in the subgroup of individuals that actually had the highest amount of pain, with higher levels of narcotics, we saw a reduction or a trend towards lower narcotic use. And we've seen this anecdotally, where patients have now started to use this tool, have been able to better manage their pain, not only in the hospital, but even outside of the hospital. And so this is a real exciting area for us. And one of the things that we wanted to understand was what is going on? How is that working? So even after the individual takes the headset off, they still have pain relief, which is remarkable. You would think that maybe it's just that distraction. But for maybe an hour, 2 hours, and sometimes even as long as 24 or 48 hours afterwards, these individuals are able to control their pain and not even have an experience towards it. So this is what you're looking at is a functional MRI of individuals that have pain, and some of them are using VR and some are not. So if you look at the top row, these are individuals that have pain but are sort of your control subject. And you see all that yellow? That's activity. It's a high level of activity, kind of lights up like a Christmas tree. Now the bottom row are individuals that actually are on the VR or using the VR, and you can see it quiets down. So there's clearly some kind of neurochemical activity that's going on that is part of this process, and we believe is somehow contributing to the pain relief. Another really interesting thing that we saw was how VR can be used to help those with low vision. And one of the biggest problems we see today is, especially in the aging population, is macular degeneration. It's a common condition, and if you look at the numbers here, globally we see low vision as a huge impact, over 200 million people that have this. And it causes many issues. It helps them prevent doing their daily activities. They oftentimes require extra resources to help them. And you can see the majority of the individuals afflicted are seniors. So one of the things that we oftentimes have been looking at, specifically those in the ophthalmology space, are how can you use and leverage pieces or areas of the eye that are still intact. Because in many cases, in macular degeneration, while the macula or the fovea is injured and it causes a central blindness, the area around it is still intact. And so what researchers and ophthalmologists often try to do is they try to teach individuals to use that area to find what's called the PRL. It's called the preferred retinal locus. and then use that and be able to use to see through that. And remarkably, that does work when you can find it. But the challenge is finding it. And so using the VR software, it helps you locate it. So in this example, you can see the typical macula. This is a picture of the retina on the left-hand side, the damage, the scotoma in the middle, and then the PRL off to the side. So you can find it with the eye tracking software. It helps bring it to the center, magnifies it, and adjusts for the photophobia and all the other elements. And with this technology, we can overcome some of the barriers and help individuals see. So in a clinical trial that was performed at Johns Hopkins, where they wanted to understand how did this impact people's visions and their goals, you can see that the majority, or a good number of these individuals, had improvement in their functional status. And in fact, in their vision, in the baseline, it went from a 20/400, which is essentially legally blind, to a 20/30. So dramatic improvements in the vision that were achieved by helping the individuals find the PRL and basically enhance the imagery. And the third area which you saw was specifically around the use of VR to help those with spinal cord injury. Now this is a really interesting study. This was published in Nature, and what they wanted to do in this study was to look at individuals that had chronic paraplegia. So we're not talking about just recent injury where perhaps you need to do, and they might have gotten better by themselves. We're talking about individuals that had been undergoing extensive rehabilitation and were still paraplegics with loss of bowel and bladder in the majority of cases. And what they decided to do was to do a study where they had the VR and an exoskeleton that enabled them to walk. And then as part of that, with some intensive therapy, they were able to demonstrate improvements to their paraplegia classification. In the study, half of them were upgraded, but in follow-up, all of them were upgraded. And really what's going on, if you think about this, this isn't a complete transection of the spinal cord, but it is an injury to perhaps one of the major neural pathways. So think of the spinal cord as a highway, the highway connecting the brain to your extremities and your fingers. And it goes both directions. Your brain sends a signal, it goes down, and you're able to grab things. You touch something, it goes up. And when you injure the major artery or the major, I guess we'll call it the neural pathway, most individuals don't know what to do. But there are still other neural pathways that are intact that just have never been activated. And similar to what we saw with the eye, through this training, we're helping individuals find that extra pathway and basically learn how to use it. So what we are seeing today is really an amazing innovation that is being accomplished through the use of technology. It's helping individuals with disabilities to overcome those disabilities by helping them identify areas within their body that are still intact and then use their own willpower and their training to be able to practice and be able to develop a level of function that is now providing improved functional status and improved quality of life. This has been clinically validated in many studies, and now what we're starting to do is we're starting to think about how this can be deployed as a scalable program. So a really good example with the pain management, we're starting to look at this, how this can be deployed as a means to battle the opioid epidemic by providing this as an opioid-sparing alternative, both in the time that narcotics are prescribed by the physician, as well as potentially by the time in which individuals that are already on it, can we find ways to get them off it. And in this process, we hope to learn a lot, but we're starting to find that there is still a significant opportunity for us to be able to improve the lives of individuals with disabilities by applying this technology. Thank you.
Michael, take it away, then we'll get some questions. Go ahead, Mike.
Thank you. So I'd just like to say I think I'm one of the 1%. I'm not a patient, I don't have a PhD, and I'm not a doctor, so I feel slightly as an outsider at this conference. And the question is, why am I here? What's ARM got to do with healthcare or helping in any way? We design microprocessors. Someone earlier this morning said the cell was a bit like a computer. We are the people who design the computers, the microprocessors, the central processing unit inside of chips, which our partners manufacture, turn into phones like Samsung. Last year, our partners sold 20 billion chips with our technology in it. And it's everything from anti-lock brakes, air conditioning, inkjet printers, through to into mobile phones. So everyone in this room owns several of the products that I've helped design because all the mobile phones in the world actually use our technology. And that 20 billion chips gives us quite an insight through our partners into what's happening in mobile, what's happening in medical, what's happening in automotive. And I'd just like to talk about some of the things that I see coming from a chip technology perspective. But the first point is about half of the chips that our partners shipped, about 10 billion of them, go into mobile. And mobile has changed everything. There are some people in this room who are old enough to remember when dialing a telephone number actually meant using a dial on a phone. I think we can all see how the phone has changed the way people behave, how they interact. I turned up in Rhew with virtually no planning because I knew I could always use my phone to call my wife or look at a map or see what I do. It's changed the way we work. And I'll give some examples about how it's enabled things in healthcare that couldn't have happened without mobile technology. But I think one of the most fundamental things the mobile revolution has done has changed where and how innovation happens. It's now possible for 3 people in a bedsit, some country you've never heard of, to actually come up with technology, get it deployed, get it distributed, and turned into a product that can change millions, if not hundreds of millions of people's lives. So in some senses, it's taken innovation out of big labs, big academia, and actually put it in the hands of people who don't have degrees, might never have been to university, and possibly it's their first ever job they've ever had is working for themselves. And I think that revolution in where innovation happens is slowly coming to medical and will change actually fundamentally what happens to a lot of the people in this room. So we've talked in this morning and yesterday about things that contribute to health problems, the cost of actually managing those. My world is all about cost. I'm not really going to talk about that, but what I want to talk about is things that can change some of the ways that contribute to healthcare. And we've looked at devices you wear on your wrist that change behavior. There's now a company in Oxford in the UK that's bringing nanopore gene sequencing, DNA sequencing into a mobile device. I think there are mobile devices that are fundamentally changing how healthcare can be delivered. But this is great if you can afford $500 for a smartwatch, $3,000 for a gene sequencing plug onto your mobile phone. And we kind of thought, well, what happens if you actually want to bring the mobile revolution to people that have very little money? So 2 years ago, in collaboration with UNICEF, we had a competition which was called Change for Good. And it was kind of, how do you come up with wearables that can actually change the people's lives, that are low cost, easy to deploy? And we had lots of entrants from around the world, and we came up with 2 winners, and I'd like to quickly talk about 2 of those winners. And the first one was really, really simple. It's an RFID tag that you wear around your wrist or around the neck for children. Monitors immunization for the first 3 years of their life, where it's really hard to track and keep records in sub-Saharan Africa. After 3 years, it's deactivated, so there's no long-term issues about ID tracking. It handles the privacy idea. And it works because you can take a 20-cent RFID tag, put the technology in a mobile phone, deployed through healthcare professionals in the field, and actually bring a solution that combines real low cost with the real high tech and the back end that provides all of the facilities. And that's how, for me, mobile is changing some of the way healthcare can be delivered by enabling really low cost devices and solutions out in the field where there's virtually no infrastructure. Other end of the spectrum, machine learning is transforming the way we do design in ARM. Any task you have that you do repetitively, that you know after you've done it, if there's a good or a bad outcome, machine learning can help you. It takes us hundreds of man-years to actually develop a microprocessor. Half of that effort goes in validating if it actually works properly. That's a task you can automate. Half of that resource we've actually been able to halve yet again by just using machine learning. It's not about fancy self-driving cars or necessarily doing diagnostic. Routine tasks can be done much better when you actually go and analyze the data. And this was my favorite machine learning example. You put it in your bathroom. It works best if you're not wearing clothes. Heart attack, heart failure, major cause in the UK of admissions to hospitals of the over 65s. I'm told that of the half the people that go into emergency care, 3/4 of them come back, and that was mostly avoidable. What this does is look at your ankles, because apparently ankle swelling is a great determinant of whether you have actually been taking your medication, if your blood pressure is changing, or whether you are now becoming at risk of a heart attack and you need to see the doctor, potentially have a represcription of what you're doing or a change in what your behaviors are. So it's done with machine learning, it's done with cameras. I thought that's a great example of machine learning. What I found even more exciting was when you open it up and look inside, it's built up out of the components that you might have, or I'd have lying around my house. An Ethernet switch, a USB dongle that's actually a phone to do the data service, to do the machine learning back in the cloud. And then a bunch of development boards that have been enabled because the mobile phone has taken in the last 10, 15 years high performance compute from being a $10,000 problem and turning it into a $10 problem. So you can then suddenly put that with cameras, with all the recognition software that's been developed on the back of people wanting to take nicer photographs of themselves. And suddenly 3 people can come up with a product, build a prototype, ship 1,000 of them. You're not going to ship 1 million of these, you're going to have to go to proper manufacturing for that. But you can actually transform how products are developed. Perhaps another example is how I think people think about drugs. I think about drugs now being enabled with software, the continuous monitoring of how those drugs are delivered, what effect those drugs have on people, and actually change dynamically the way you may do prescriptions. So I think it's not going to be a static, go to the doctor and have your prescription. It's get your prescription and the software service that will come with that actually monitors how you take those drugs and what efficacy they have. I'll skip this example. It's glasses that look at you rather than glasses that look out and help you again in facial palsy and diagnosing of Alzheimer's. I had elevated PSA a few years ago, so I started to pay attention to research in prostate cancer, and I saw this article about dogs that sniff cancer. I thought, really? Is that real? Is that fake news? No, it's real. I dug a little bit deeper, and you discover that actually, lung cancer, again, major cause of death. Earlier you diagnose lung cancer, the more important it is. Early diagnosis doesn't really happen. Not surprisingly, if you have lung cancer, then quite a lot of what you breathe out can actually inform someone that you have lung cancer. And if you take the technology that's been developed over the years for sniffing out explosive devices, turns out you can modify that and turn it into something that actually can start to recognize what the outputs from someone with lung cancer is, and you can start to do early diagnostics. It's currently the size of your fingernail. In a few years' time, you could see how every mobile phone would automatically be analyzing your breath every time you were making a phone call, doing diagnostics of what diseases you might have, but have yet to present any symptoms of whatsoever. So again, I think the technology will be there. You can draw the lines and see 10, 15 years when it just becomes embedded in all the electronics around you. You want to go to a little bit further, we're doing research projects with CSNE, Center for Sensorineural Engineering. Here's an example of one we did with Michigan University. It's just over a cubic millimeter, slightly bigger when you encapsulate it in plastic. It's a layer of chips, battery at the bottom, memory, computer at the top, a little bit of comms on the top of it, small enough that you can actually do trials to implant it in a brain. And you can then start to do remote monitoring of tumor size without having to do the MRIs because it's just got a little pressure sensor in it. And so by measuring the pressure, you know what's happening to the tumor, what's happening if you've got intracranial pressure, do you need to have draining? And you start to do that in a way that actually reduces cost, and you now suddenly have a dynamic tracking of that, not the point measurement that you go when you have the MRI. So that's a fairly kind of extreme end of implantable electronics, but it goes, of all these things, one stage further, and it becomes smaller than a grain of rice. And beyond that, I'd like to show you this video. A gentleman who has broken spinal cord, so is unable to move his legs or his arms. And what you'll see is he has 2 implants in his head and 36 electrodes in his arm, and therefore by measuring his brain and then generating computer-generated stimuli to the electrodes implanted in his arm, he's feeding himself. So that's out of the brain, into the computer, back into his arm to feed himself. It's not really practical at the moment for mass deployment, but for me, that's kind of the extreme of where implantable electronics is going. I think it's really quite, for me, boggling as to what is going to come. I'm repulsed by a lot of it, but that kind of tells me that's what's going to happen. And the final, to wrap up, the final winner of our Change for Good appeal for, remember, the devices that had to be low cost and wearable. And we looked at this one for a moment and did a double take, and I kind of went, unambiguously, this is a winner, because unambiguously, it's wearable and it changes people's lives. And it is soap on a string. It's a bar of coloured soap. You wear it round your neck if you're a teacher in a school. You can then cover your kids' hands with a pretty picture. You send them off to wash their hands. They come back. They have to raise their hands up. And if the soap's gone, you know they've washed their hands. So, you know, really simple technology. It's wearable, changes people's lives. And just for us all to remember that you can get carried away with stuff. Sometimes it's just as simple as washing your hands. Thank you very much.
Nicely done, David. I must say, as I was getting ready for this panel, a few weeks ago, I had no idea what ARM was. And I think it is the biggest company I've never heard of in the world. Gargantuan. You did a little intro, but for many, how many of you knew what ARM was before the session started? I mean, probably some of your customers probably knew. But, it's 2%, of the audience. And it's surprising. Are you driven to make smaller technologies available because people need them from you, or do you have your own R&D effort and then wonderful innovators say, hey, no, my goodness, they made things a millimeter cube. We can now start making intracranial sensors.
I mean, I guess we've got to where we've done because we're very happy going. We specialize in what we do. We understand that we don't get the public limelight, and we work with our partners, and our partners add a significant amount of technology around what we do to turn our stuff into a mobile phone or our stuff into an inkjet printer or into a brain implant. And so we partner with them, and I've got some research guys who go out and do some of the extreme stuff in partnership to push the internal teams to say, this is what it'll be like in 20 years, because our development cycles are 5+ years. So you have to kind of dream what it's going to be like to make sure what you're designing can deliver in the future.
And do we know what the barrier is to size yet? If you had to project out 10 years, how small can these chips be, allowing us to do things that we can't even imagine today?
Well, the whole Moore's law slowing, it was, for the last 10 years, it's been the last 3 years, we've got 3 years left. We've got 3 years left. Right now, I'd say we've got about 3 years left. Yeah. But actually, for me, it doesn't matter. I think the whole industry has actually had it quite easy for the last 30 years. If Moore's law stopped today, innovation doesn't. We kind of went back and said, we need to do a new microprocessor that's really teeny tiny. The design came out to be about the same number of transistors as the original thing we did in 1983. But we came up with a completely different way of doing it that was much better. And I think more transistors has undoubtedly fueled this revolution. But even if it slows down, you just work a bit harder. There's still an awful lot of innovation out there.
David, much of what we've heard today is a little intimidating to the average person. Where does the regulatory system start to play a role? How do we get folks comfortable? And that's why having this conference at the Vatican is so important, because I suspect leaders will turn to faith-based institutions as well.
Yeah, that's a great question. I think what we're seeing is that there's a consumerization of healthcare, not just from the expectations of what consumers want, but also how consumer devices can be used as medical treatments. Much of this is currently being used in academic medical centers, sometimes in the settings of clinical trials. But for the example that you saw with the vision, that's being used by over 80 ophthalmology centers across the country, including UCLA, Johns Hopkins, Stanford, et cetera. So some of these are actually being used, but most people don't know about it, which is really surprising. Virtual reality for pain management, that is something that we are absolutely seeing a huge amount of interest in, because it can serve as a mechanism for us to think of ways to improve the quality of life, but also potentially decrease narcotic usage. So the discussions that would potentially be had would first be in the clinical setting, is this being managed? But then when you move outside of that, what kind of statements can you make about what it can and can't do? So long as it's under the jurisdiction or control of a clinician, under their guidance on off-label use, that's where much of this is being done. But at some point, it'll become pretty apparent that the data supports its use for certain indications, and then that will probably be the time in which you'll start seeing FDA indications.
Being thoughtful about the potential risks, I'd love each of you to articulate to the audience what does concern you, because there are probably some lines that are not so visible to us that you're probably aware of, lines we don't want to cross, or if we do cross them, we should be cognizant of the perils.
I guess for me, some of the lines, yeah, perhaps already have been crossed. I think as a technologist, it's a responsibility to flag up what is possible. Society ends up determining what becomes legal. I don't think that will be the same in all the different regions that we operate in the world. I think the moral underpinnings are different in different countries, and we'll end up with fundamentally different regulation about what you can and can't do in different parts of the world. So I don't think there is going to be a single answer. I think it's a responsibility, again, of the technologists to ensure that the systems we produce actually work to protect people's integrity, the security of their data. I mean, at the moment, yes, you can hack the pacemaker. Yes, your data probably goes unencrypted into the cloud in some applications. There are things that we need to do to ensure that safe and secure systems can be built. How they get deployed, I don't know.
Yeah, I would say the things that we see today, we work with a large number of the medical device companies, and as you can imagine, there is a strong push towards consumerizing the devices that people pull out. So rather than pulling out that big clunky device that calls attention to your fact that you have diabetes or that you have bladder incontinence, now you pull out a smartphone. And where the line gets crossed is where the FDA oftentimes comes in. The line up to now is if you want to see data, you can do it on any mobile device, whether it's a phone or a tablet. But if you need to control the actual mechanism of action, whether it's administering insulin or it's administering a life-saving shock, that becomes then a true medical device. And that is the challenge that you run into if you just simply want to use your phone as that medical device, because let's say, and this, I'm not sure if this ever happened to you, but you're doing something and you get that update, and it just starts updating on its own. Well, you don't want that if it's administering insulin. So that's why we have actually had to work very closely in lockstep. When you get to that point where it's truly a medical device, you have to consider all the elements, the battery life. Are you using the Bluetooth? Is it draining? Are the apps now draining it so that you can't necessarily use this on a regular basis? Are there other things that could interfere? You've just downloaded a new app that now interferes with yours. So those are the considerations, and for that reason, I believe that there is a certain amount of regulation in place to ensure that the safety is ensured. But what we see today in the world of being able to view data, absolutely huge opportunities. Where we want to go, though, is to completely make it so seamless that you literally don't even recognize it's your phone, or you don't even have to manage it yourself.
Thank you both very much. Wonderfully done.